Knee pain exams can feel overwhelming. There are dozens of orthopedic tests, Lachman's, Thessaly's, anterior drawer, and many students try to memorize all of them for OSCEs. But experienced clinicians don't actually approach knee pain that way. Instead, they used a few key focused diagnostic forks to narrow the problem quickly. In this video, I'll show you the ScrubNotes clinical framework that helps you move from knee pain to a focused diagnosis in just a few steps. And later in the video, I'll show you one diagnostic fork that quickly narrows most knee injuries before you even start running orthos. At ScrubNotes, we approach every chief complaint using the same three-step framework. First, check for safety. Could this represent something dangerous? Second, look for patterns. What clues in the history or exam narrow the possibilities? And third, use key diagnostic forks. These are the decision points that guide which tests we actually run. So that's the approach we'll use for this case of a 54-year-old patient with knee pain. When someone presents with knee pain, we first start by clarifying the complaint. Where exactly is the pain? Was there a twisting injury or trauma? Does the knee ever catch or lock? And at the same time, we screen for red flags. Things like inability to bear weight, severe trauma, large joint effusion, fever infection risk, and true mechanical locking. These findings may suggest more serious pathology like fracture, septic arthritis, or major ligament injury. So before anything else, we want to make sure there are no dangerous causes of knee pain. This is our starting differential list for knee pain. Instead of memorizing dozens of diagnoses, it helps to group them into a few major categories. Mechanical causes like meniscus tear, ligament injuries such as to the ACL, MCL, or LCL, patellofemoral pain, tendon injuries like patellar or quadriceps tendinopathy. You could also have degenerative causes like osteoarthritis, degenerative meniscus tears. And it's always good to keep serious causes in mind like fracture, septic arthritis, or crystal arthropathy. The goal here isn't to memorize everything, it's to quickly identify which category the patient falls into. The history gives us some of the most important diagnostic clues. One of the most helpful questions is, what were you doing when the pain started? The mechanism of injury is extremely important for knee injuries. For example, twisting injuries often suggest meniscus tears. Non-contact pivot injuries raise suspicion for an ACL injury. Anterior knee pain with stairs or squatting often suggests patellofemoral pain syndrome. We also ask about mechanical symptoms. Locking or catching is strongly suggestive of meniscus pathology, and swelling patterns can help as well. Immediate swelling after trauma raises concern for ligament injury, while delayed swelling is more consistent with meniscus pathology. Let's apply this framework to a case. A 54-year-old male presents with right knee pain for 4 days. The pain began after twisting his knee while standing up from a deep squat during a workout. He felt a sudden, sharp pain along the medial line, but was able to keep walking afterwards. Since the injury, he reports intermittent aching and a sensation that the knee locks when trying to fully extend it. Pain worsens with twisting, squatting, and going downstairs. So already we have some really important pattern clues here. This slide outlines the ScrubNotes exam framework for knee pain. Before we jump into ortho tests, we want to run what I call the ScrubNotes MSK algorithm. First is the pre-3 safety screen. Then we look for pattern clues in the history and motion exam. Next comes a diagnostic fork, where we determine whether symptoms are suggestive of something like meniscus pathology, ligament instability, or other mechanical cause. And then only after that do we run targeted ortho clusters. This stepwise approach prevents us from running random tests and helps the diagnosis emerge much more efficiently. If you want a quick reference for this exam flow, I've organized the pre-3 framework and orthopedic clusters in the ScrubNotes Orthodex. The pre-3 is our structural safety screen. It answers 3 key questions. First, with observation, we can look for swelling, deformity, bruising, or alignment changes such as genu valgum or varus. Second, fracture screening. If trauma is present, we can use the Ottawa knee rules and palpate key bony landmarks. And third, we're checking active range of motion. So flexion and extension can reveal pain patterns or mechanical restriction. The key idea is this. Before focusing on special tests, we confirm the knee is structurally safe to examine further. Remember earlier when I mentioned a shortcut that helps distinguish meniscus injuries from ligament instability? Well, this is it. After the pre-3, we look closely at passive and active range of motion, and then mechanical symptoms. If the patient reports locking or catching, that strongly suggests meniscus pathology. In contrast, feelings of instability or giving away raise concern for ligament injury. This diagnostic fork helps determine which orthopedic cluster to test next. Only after narrowing the differential do we run targeted orthopedic tests. For suspected meniscus pathology, we use tests like Thessaly, McMurray, joint line tenderness. For ligament injuries, we might run Lockman's for ACL, varus and valgus stress testing of the MCL and LCL. And again, the key idea is that we choose clusters and orthos based on our earlier findings, rather than just running every orthopedic test. If you want quick visual summaries for these orthopedic clusters across the spine, shoulder, knee, and hip, I've organized them into the ScrubNotes Orthodex, linked below. Let's circle back to our case and apply the framework. The pre-3 showed no fracture or major instability. Active range of motion was largely preserved. However, the patient had focal medial joint line tenderness. The Thessaly test reproduced his pain in catching, and ligament instability tests such as Lockman and valgus stress were negative. When we follow the framework, the pre-3, diagnostic fork, and targeted orthos, this pattern then strongly suggests meniscus pathology. Putting everything together, we have a 54-year-old patient with acute medial knee pain following a twisting injury. The history demonstrates mechanical symptoms, including catching and intermittent locking. The physical exam reveals medial joint line tenderness and positive meniscus provocation testing, while ligament stability tests are negative. The presentation is most consistent with a medial meniscus tear, likely degenerative with an acute twisting motion. Importantly here is there's no evidence of ligament instability, fracture, or significant effusion. Before we finish, here are 3 mistakes students often make during a knee pain chief complaint. First, skipping joint line palpation. Second, ignoring mechanical symptoms like locking or catching. And third, running just too many random orthopedic tests. If a patient has locking after a twisting injury, that pattern should immediately guide you toward the meniscal cluster. To summarize the ScrubNotes MSK framework, first we run the pre-3 safety screen. Next, we look for pattern clues like twisting injury or mechanical locking. Then we use the diagnostic fork to determine which orthopedic clusters to run. When knee pain follows a twisting injury and mechanical symptoms are present, the most likely diagnosis is meniscus pathology. Once you start thinking about knee pain through these diagnostic forks, the entire evaluation becomes much more smooth and efficient. If you want quick reference versions of the pre-3 framework and orthopedic tests, those are included in the ScrubNotes Orthodex linked below. Thanks for watching. If you found this helpful, check out the rest of the ScrubNotes Chief Complaint Series, where we break down other common clinical presentations in the same way.